So this is week 13 of your course and module 1 for pediatric nutrition. So the learning objectives for this week are to identify the 6 components of a pediatric nutrition assessment, utilize appropriate growth charts for both infants and children, utilize appropriate equations to determine a child's energy, protein, and fluid needs, and apply these concepts to a basic pediatric assessment. As a side note, I noticed in the picture below that appears to be a copy of the Bible, which isn't to imply that this course is the holy grail of all pediatric nutrition courses. So the 6 components that an RD should look at to perform a successful nutrition assessment are patient history, food and nutrition history, laboratory, medications, anthropometrics along with the NFPE, and estimated needs. When we're talking about patient history, there's several different parts to this. In the medical history, obviously the first thing you want to find out is, why are you seeing them? What is their chief complaint? Is this a patient that is inpatient and acutely ill, chronically ill, or is this an outpatient that you're seeing with a chronic disease? Second is, what is their current status? Are they in the PICU on a vent, intubated, or are they sitting and chatting and talking with you as a normal kid would do? The next is, what is their chronic disease status? Is this a child with relatively little past medical history, or is it a child with a lot of past medical history? This often has a major effect on their nutritional status. Another factor to look at is the psychiatric, surgical, and diagnostic procedures the patient may have received. As an example, have they recently spent time in the psychiatric ward for an eating disorder, or perhaps had a bowel resection as a surgical patient? And are there any diagnostic procedures such as a PET scan or bone marrow biopsy for cancer that may have nutritional implications? Next is medical therapies, which may include something like chemotherapy, insulin therapy, radiation, or dialysis. For GI history, you want to take a look from top to bottom. How's their mouth? Is there any oral pain? Are their teeth okay? Are they able to eat and chew and swallow properly? How's their bowel movements? Is there diarrhea? Is there constipation? Basically just a snapshot of current and past problems they may have encountered there. And for infants, it's important to obtain a prenatal and birth history. For development history, basically it's taking a look and seeing if the patient has progressed as expected to their current age. As in, are they doing the normal things that a child that age should be expected to do? You can find references for these on places like the WHO or CDC that will give you these milestones. An RD should look at motor development, cognitive development, and sexual maturation. Family and social history is a big part of any nutrition assessment for a pediatric patient. It's important to consider who the members of the household are, who is taking care of the child. Are there 2 parents? Is there 1 parent? Are they in foster care? And what is the ability of the family to purchase and prepare food? This has a big impact on providing complete nutrition for a child. Also, what is the setting for meals and snacks? How many meals per day and what time? Is this a child who eats 3 meals a day and a couple of snacks, or are they only provided 1 meal per day? Or is this a child who snacks all day long without eating a regular meal? Next are cultural and religious food preferences and feeding practices. Alaska has a very diverse population, and there are many groups who have opinions, strong opinions, on certain foods not being fed to their children, certain formulas not being fed to their children, for religious and personal preference. You have to work around these, but always remembering that in the long run, you have to try to prescribe what is nutritionally best for the child. Another important factor to take a look at is the level of family function or dysfunction. A lot of times when a patient is in the hospital and it is a child, the family stress and emotions run very high. So when you are interviewing a parent, always take that in consideration and give them the benefit of the doubt. Think of how you would feel if your own child were in the same situation. Finally, the caregiver's expectations and attitude towards the child's health and nutrition plays an important part. Some parents are very engaged in what their children receive nutritionally, others, not so much. And you can see this to the point of nutritional neglect. Next is food and nutrition history. This is a primary determinant of nutritional status in a child. The main question is the child's current intake meeting nutritional needs in the context of current clinical status, growth pattern, and development? Another thing to remember is that an accurate estimate of energy, protein, and micronutrient intake should be routinely assessed. As in, take a look at the whole picture again. The nutritional status of children changes rapidly, and just because you saw them a week, a month, a year ago doesn't mean they're eating the same things or that their estimated needs are equivalent to what they were. A patient's intake can be obtained by history or direct observation or both. A lot of times I'll go into a patient's room during a meal time if the parents are okay with it, just to see what the child is doing. What are they eating? How much are they eating? Is there food preferences that I can use to determine nutritional adequacy? Food and nutrition history may include the type and amount of food, beverages, breast milk consumed during the day, with preferences, likes, and dislikes, the preparation methods for food. Does this family fry food a lot? Is this a holistic family that is vegetarian? Are they mixing the formula correctly? This is an error that we see frequently on children who are sent home with special recipes. I've seen parents who were supposed to be mixing a 24 cal per ounce recipe end up mixing a 35 to 40 cal per ounce recipe, and parents supposed to be mixing a 30 cal per ounce recipe actually mixing an 18 cal per ounce recipe. It's no wonder the child was losing significant weight. Another thing you want to look at is any food allergies or intolerances that the patient has or are prevalent in family history. One thing we're finding in the NICU is that if families have a history of lactose intolerance, then the infant is quite likely not to tolerate most of our dairy-based formulas that contain lactose. So we really have to keep an eye on that. If the patient is breastfeeding, how many times are they breastfeeding per day and for what length of time? And importantly, are they having wet diapers and how frequently? Also, is the infant receiving supplemental bottle feedings? A lot of times children will go home if mom doesn't have an adequate supply of breast milk with breast and bottle feedings. If there's table foods, once again, the frequency of meals, snacks, and timing. Another thing to consider is, has the child been on a special diet in the past? And are they currently on it? And if they were on one, was it followed by a doctor or another dietitian? Again, consider cultural and family eating practices. And lastly, physical activity and media viewing behaviors. These are especially important as we're starting to see more adult diseases in pediatrics. That is something like type 2 diabetes versus type 1, and also heart disease, because our population has moved towards inactivity and spends an inordinate amount of hours sitting around on their media. This is important, believe it or not, for teens all the way down to very young children, and something we're really having to take into account more and more with obtaining a food nutrition history. Next is laboratory. When it's available, you can use it for screening for malnutrition, evaluation of nutritional status, diagnosis of insufficient intakes of specific nutrients, monitoring of nutritional rehabilitation or MNT therapy, and following acute versus chronic disease processes. Most of the pediatric labs that you're looking at are also similar to what you would find in adults. As a reference, the labs are noted in their panels below. A CMP, of course, is a complete metabolic panel, a BMP, basic metabolic panel, RFP, renal function panel, and then your hepatic panels and individual labs as ordered. Things you could be looking at are CBC, electrolytes, glucose, sputin and creatinine, liver function, including albumin, AST, ALT, alk phos, T-bili, and then other labs that might include calcium, phosphorus, and magnesium. Some other common pertinent tests you might see in children are CRP, ferritin, sweat chloride, that's to diagnose cystic fibrosis, prealbumin, vitamin D25OH for vitamin D deficiency, really common in Alaska, corrected reticulocyte count. We do that a lot in infants to determine anemia of prematurity, or if the bone marrow is able to produce red blood cells appropriately. Look at blood gases, hemoglobin A1C, and fractionated bilirubin. We fractionate bilirubin when we're concerned for cholestasis. When it comes to interpreting the results, it's similar to what you would be looking for in adults. Some common Alaska pediatric lab anomalies are anemia. There's several different types. Vitamin D deficiency, as we mentioned before. Electrolyte imbalances. Diabetes type 1 and 2. Cholestasis, metabolic bone disease, cystic fibrosis, and abnormal newborn metabolic screens or SNP array. A SNP array is a genetic test sent out to determine if there is a genetic anomaly or component that needs to be addressed. For more information, you can see your supplemental reference for lab tested malnutrition, which is located on your dashboard. When it comes to medications, these are some of the more common ones you'll see in pediatrics, along with examples of brand name drugs. You can look for vitamin and mineral supplements, anti-secretory drugs like Pepcid, antibiotics, diuretics, most common is Lasix and Alzactazide, corticosteroids, anticonvulsants, the most common is Keppra, gabapentin, appetite stimulant, you'll see Megace, Periactin, and Marinol all used, anti-nausea, most commonly used for children is Zofran, and then disease-specific drugs. We'll be discussing some of the drugs in the PICU during week 3 when we address critical care. And once again, you can see your supplemental reference on your dashboard for some common drug and nutrient interactions. Next, we're going to be moving on to anthropometrics. Growth is the primary outcome measurement of nutritional status in children. It is defined as an increase in size and the development of maturity. Growth velocity is defined as the rate of change in weight or height and length over time. These must be monitored at regular intervals during childhood and adolescence. The standards in preterm infants and children less than 2 years old are to monitor length for age, weight for age, head circumference for age, and weight for length. In children aged 2 to 18, you're looking for height for age, weight for age, and BMI for age. When it comes to anthropometric measurements, there are some variables that can play a fact in getting an accurate reading. For weight, different scales can yield different results. One of the things you want to make sure is that your medical scales are regularly calibrated. And then consider how the weight was obtained. Was it a standing scale? Was it a bed scale? Was the bed scale zeroed out? Or was it a Hoyer lift? This can make a big difference in getting an accurate result and for tracking weight accurately over time. The next anthropometric measurement to look at is length and height. These are probably the most inaccurate measurements that you see in pediatrics. And this is for many different reasons. It could be due to a medical condition, contractures, physical impairment, and a lack of provider education. Sometimes the inconsistency in the way a length is obtained affects the growth chart, as in, did the provider use a length board on an infant, or did they simply use a tape measure? And on a child, did they use a tape measure, or did they actually use a stadiometer? Alternate methods would be to use arm span, knee height, or tibia length, but I recommend if you do try to use those that you have had some experience and understand how to convert them into proper length. The next anthropometric measurement is head circumference, and this can indicate growth when an accurate length is not available. It is used on infants and toddlers up until the age of 24 to 36 months and taken to the nearest 1 millimeter. The nice thing about this is that it is the last thing affected by poor nutrition. Mid-upper arm circumference is the last anthropometric, and it's used in determining malnutrition in children 6 to 16 months when compared to WHO standards. This is also useful when weight is unreliable due to edema and ascites. Now on to the growth charts. The CDC recommends using the WHO 0 to 2-year-old charts for males and females, then transitioning to CDC 0 to 20-year-old charts for males and females. These growth charts, along with 2 articles regarding the WHO and CDC charts, can be found on your dashboard. There are several other specialty growth charts that will be reviewed, along with a more in-depth look at Z-scores, NFPE, and diagnosing pediatric malnutrition during week 2. Now on to using the growth chart. This is an example of how you would plot on the growth chart. For this, we are using a 16-year-old girl with a weight of 50 kilos and a height of 160 centimeters. Generally speaking, in medical circles, we do use the metric system to track weight and height, but a lot of provider offices use inches and pounds. You'll notice on the growth chart that in this case, weight and stature are on the vertical sides and age is on the horizontal side. So you simply find the age you're looking for. In this case, it's 16 years old, and find the height, which is 160 centimeters. Where they intersect is the percentile, which in this case is approximately the 50th percentile. This will give you a general idea of where the child plots on the growth chart and a possible growth curve. When it comes to getting exact percentiles and Z-scores, there are easier ways to do it. Most healthcare facilities that have an EMR will automatically plot anthropometrics on a child's growth chart, giving both a more accurate percentile and Z-scores. If this is unavailable, I suggest going to PD Tools that has many growth chart references where data can be plugged in. This results in an accurate percentile and Z-score. There's a lot of different calculators over there, so I'd check it out. The next question is, how often should anthropometrics be repeated? And that depends on the patient's age and disease process. Generally, the younger the patient, the more frequent they should be measured and weighed. ICU anthropometrics will be discussed week 3. Just as an example, a baby is likely to be weighed every day with the OFC and length done weekly. For a teenager, unless there's a need to track weight for catabolic reasons or fluid reasons, likely the weight would be repeated weekly, and possibly you won't get a new height while the patient is inpatient. Next, we're going to move on to expected weight gain. Expected weight gain is important for setting and evaluating weight gain goals. It's also useful for tracking adequate weight gain over a period of time. To calculate it, you take the current weight minus the previous weight, which equals a difference, and divide that by the number of days, which equals weight gain velocity. For example, if I take a patient's weight today and minus his weight from last week, then divide that by 7 days, that will give me the weight gain velocity over the past week. This should most definitely be included in your anthropometric assessment and evaluation. So, with your data now gathered, it's appropriate to move on to the next step, and that is to assess estimated needs. Just as in adults, there are many, many ways to do this and many different opinions on how to do this. For this course, we are using the standards set forth by the WHO, RDA, DRI, and Aspen for critical care in week 3. The reasoning for this is that it is simple to use and adjust up or down for increased or decreased needs. Plus, these are parameters I personally have used at Primary Children's Medical Center, Phoenix Children's Hospital, and the Children's Hospital at Providence. In short, they work under most circumstances. You'll want to get your pediatric assessment cheat sheet, which is located in the Learning Blocks section of your dashboard. This has all of these charts on there and many helpful hints in how to determine estimated needs. For infants, we are going to use the FAO, WHO, and UNI recommendations for estimated needs. This is figured in calories per kilogram in pediatrics and best used on a 10 kcal per kilo range. So you'll notice there's a slight difference between breastfed and formula-fed babies, and that's because breast milk has a better bioavailability. You're welcome to use the general range. That's perfectly acceptable for infants if you're more comfortable doing that. If you have some experience with babies and want to kind of create your own bracket, I suggest taking the recommendation as your middle target and then bracketing 10 around. So as an example, for a breastfed baby that is 2 months old, the recommendation is 97 calories per kilo. If the baby were on the upper edge of the growth chart, I would probably recommend 90 to 100 calories per kilo. If they were on the lower range of the growth chart, I would probably recommend bumping that up to 95 to 105 calories per kilo. That's the beauty of doing it this way, in that you can accommodate for those children on the growth charts that are kind of starting to fall off to the edges. This is the chart you will use for babies that are born term up through 12 months of age. Now moving on to energy needs for children that are greater than 1 year old. For this, we're going to do a combination of the WHO and the RDA. The boys and girls columns to the left are the WHO. The columns to the right after the age of 10 reflect the RDA. This is due to the observed results that the WHO is a little too high in these ages and may not accurately predict U.S. and Canadian children estimated energy needs. In other words, it tends to overfeed them. Once again, just as in infants, this is figured in kcals per kg, and it's still best to use the 10 kcal per kg range. So moving on to protein and fluid needs. For protein, we're going to use the RDA, and it's fairly simple in that you just plug the kilograms in to the formula that fits the patient. So if I have a baby that is 7 to 12 months old and weighs 10 kilos, I simply plug that into the RDA, 1.2 to 1.7 grams per kilogram, and that spits out how much he needs, which is basically 12 to 17 grams per day. Should the baby require more for critical illness, then I'd bump it up into the 2.0 to 3.0 grams per kilo range. So fairly simple to use and pretty straightforward there. For fluids, we're going to use the Holiday-Seeger method, which is also based on kilograms, and you just plug it into the equation once again. So for a baby that weighs 7 kilograms, We're going to plug it into the first formula. 7 times 100 is 700. For a baby that weighs 11 kilograms, we're going to plug it into the second one. That is 1 kilo over 10. So 1 times 50 is 50, plus 1,000 is 1,050 mils per day. Once the kid reaches greater than 65 kilograms, and that's definitely adult size, it's okay to use the 1 mil per kcal as a general rule. This can be adjusted if need be based on treatment or actual needs. One thing to always remember is to check with your practitioner prior to adding any free fluids, and that basically applies to tube feedings. So finally, putting it all together. Once you've gathered all of your information and histories and calculated your estimated needs, it's time to formulate a nutritional plan of care. And that's, of course, based on the information and data gathered. Some information may not be available based on circumstances, but use what you have and add to it as more becomes available. A complete care plan should reflect as accurately as possible a snapshot of nutritional history and where they are now, plus a nutritional plan of care moving forward. A couple of final thoughts and recommendations is to remember that less is more in charting. Providers are often willing to skip a long, wordy RD note and move on to something else. Make sure that you're brief and to the point, and remember complete sentences are not required. Put your recommendations at the top in clear, easy to read format. The top of the note is generally all some providers will look at. And that's the end of this module. Hopefully, at this point, you will be able to assess a pediatric patient, gather your histories, and put together a clear nutritional plan of care. Once again, if you have any questions, make sure that you post them so that we can work on them together. Thanks for listening, and I'll see you in Module 2.